Good morning, everyone. My name is Dr. Karima Becetti, rheumatology consultant at Hamad Medical Corporation in Doha, Qatar. I would like to start by thanking the review committee for accepting our abstract. It is a great pleasure being with you virtually to present our work on nail fold video capillaroscopy patterns and associated clinical features in systemic sclerosis in Qatar. I do not have any disclosures pertinent to this talk. As we all know, microvascular abnormalities are key feature in systemic sclerosis. Together with fibrosis and autoimmunity, they constitute the hallmark of the pathogenesis in this disease. In fact, some capillary changes can be observed long before the development of systemic sclerosis. And with the presence of capillaries that run perpendicular to the skin surface at the level of the nail fold, we have an excellent window to evaluate these microvascular abnormalities. And this can be done using nail fold video capillaroscopy, which is non-invasive, safe, and inexpensive. Due to their importance, abnormalities in nail fold capillaries were included in the 2013 ACR-ULR classification criteria for systemic sclerosis, and nail fold video capillaroscopy is now more widely used as well as standardized. The role of nail fold video capillaroscopy is well established in distinguishing primary from secondary Raynaud's phenomenon. In other words, its main application is in the early identification of patients with Raynaud's phenomenon who are more likely to develop scleroderma or scleroderma spectrum disorder. Studies have shown that abnormal findings on capillaroscopy at baseline, together with the presence of scleroderma-specific autoantibodies, indicate a very high probability of definite scleroderma developing, whereas the absence of these abnormalities rule out such outcomes. Multiple abnormalities can be seen on nail fold video capillaroscopy, including giant capillaries, microhemorrhages, loss of capillaries, neovascularization, and avascular areas. And in systemic sclerosis, 3 distinct patterns have been identified. So compared to the normal hairpin morphology and density of 7 capillaries or more in 1 millimeter, in the early scleroderma pattern, we see a preservation of capillary density, but the presence of giant capillaries and microhemorrhages. In the active pattern, we start seeing a decrease in capillary density and more giants, more microhemorrhages. While in the late pattern, there is a significant reduction in capillary density, and instead we see more avascular areas and areas of severe disorganization marking neoangiogenesis. Now, in addition to its diagnostic role, many studies have looked into the prognostic role of nail fold video capillaroscopy in scleroderma. They showed that patients with late pattern had an increased risk for having active disease and showing moderate to severe skin or visceral involvement. Digital ulcerations were associated with a late pattern and decreased capillary density, which in turn was also found to be associate with established pulmonary arterial hypertension as well as ground glass lung opacities. In general, progressive capillary loss and the more severe nail fold video capillaroscopy pattern in the form of either active or late patterns were identified as potential biomarkers for disease progression. This is still ongoing, and we therefore decided to conduct a study to look at the nail fold video capillaroscopy patterns in patients with scleroderma in Qatar and evaluate the association between nail fold video capillaroscopy patterns and parameters with disease-specific features. The study was a cross-sectional study. It used the baseline data collected as part of a larger scleroderma cohort study in Qatar. It included consecutive patients with a diagnosis of scleroderma based on the 2013 ACR-ULR classification criteria. Those patients are following the rheumatology clinic at Hamad Medical Corporation in Doha, Qatar. They're adults and provided a signed informed consent. We collected data on their demographic information, disease-specific information, including subsets, duration, clinical manifestation, their modified Rodnan skin score, lab and imaging data from a thorough electronic medical record review. And every patient underwent nail fold videocapillaroscopy evaluation. The images were interpreted by two investigators using the standardized way, looking at the density, dimensions of the capillaries, the presence or absence of abnormal morphology, hemorrhages. And each patient was then classified into having a normal a pattern, non-specific abnormalities, or one of the three scleroderma patterns, early, active, or late. We started by calculating the number and frequency of the different nail fold videocapillaroscopy patterns. We then classified the patient into having either non-severe patterns if they had normal, non-specific, or early patterns, or severe pattern if they have had active or late pattern. We compared those with the non-severe pattern to those with the severe patterns with regards to the demographics and clinical variables, and we also correlated these variables with capillary density. So the study included 20 scleroderma patients. 70%, as expected, were women. The mean age was about 42 years and the mean disease duration about 5 years. 60% had the diffuse cutaneous subset of the disease, and 55% had anti-SCL70. Raynaud's phenomenon was reported in 65%, with 35% having digital ulcerations. ILD was present in 75% of patients, and only one patient had pulmonary arterial hypertension. The mean modified Rodnan skin score was 13.6. 44% of patients had the active pattern on nail fold videocapillaroscopy, and 27% had the late pattern. So together, 71% had the severe pattern on their evaluation. 17% had early pattern, and few had normal or non-specific changes. Now, comparing the patients with severe and non-severe patterns, we see that the patients having diffuse and limited subsets of the disease were more likely to have the severe pattern in 60% and 100% in respectively. They were also more likely to develop or to report Raynaud's phenomenon if they had the severe pattern, 92%, compared to 8% if they had non-severe pattern, with a significant p-value of 0.01. Digital ulceration were solely present in those with the severe pattern. No differences were seen regarding the other variables. Capillary density did not correlate with the presence or absence of anti-SCL70, but when looking at the clinical manifestations, you'll see that the capillary density was numerically lower in patients with Raynaud's phenomenon, digital ulcerations, telangiectasias, and ILD, but it was only statistically significantly lower in patients with Raynaud's phenomenon, with a p-value of 0.02. So in the small sample of patients with scleroderma in Qatar, we saw that active and late patterns were the most common, and the presence of these severe patterns was associated with vascular manifestations, including Raynaud's phenomenon and digital ulcerations. Capillary density was numerically lower in patients with vascular and visceral involvement. However, it was only statistically significantly so in Raynaud's phenomenon. These findings are similar to what was previously reported on the association between nail fold videocapillaroscopy and disease-specific factors. This is, to our best knowledge, the first study to report on nail fold videocapillaroscopy in systemic sclerosis in Qatar and the region. And important strengths include the use of nail fold videocapillaroscopy and a standardized approach to interpreting the images by two different assessors. There are, however, several limitations to consider, including the small size. It's one center study, and some clinical manifestations were really underrepresented, including pulmonary arterial hypertension, which was present in one patient, and scleroderma crisis, which was absent. This, of course, limited the evaluation of the association of nail fold videocapillaroscopy with these manifestations. And of course, the lack of follow-up data limits the evaluation of the predictive value of nail fold videocapillaroscopy in disease progression. In conclusions, we did see in this cohort of patients in Qatar more severe nail fold videocapillaroscopy patterns in association with the presence of Raynaud's phenomenon and its complications in the form of digital ulcerations. The evaluation of nail fold capillaries carries an important diagnostic value, but needs to be recognized as potentially having important prognostic value as well. And hopefully, with a larger sample size and follow-up data, will better assess the association between clinical features and new organ development and these patterns and parameters. With this, I thank you for listening, and I'm happy to take any questions.